I'm going to go into the deep permutations of the adrenocorticotropic axes that are finding and delving into where is the problem. You will do that in endocrinology. We are just going to define hormonal pathways, where they're coming from, what they're acting upon, okay? So just understand that. Also, as I have said multiple times, everything has to have two names. So now we're getting into everything has two names or more. You're going to have to know the difference. You're going to have to know both, okay? You're going to have to understand that if you're speaking to an endocrinologist, they may refer to human growth hormone as somatotropin. And you have to be able to have that conversation with that subspecialist and understand what they're saying. So terms are going to switch back and forth. You will need to know both names, okay? Does that make sense, everybody? But I'm going to do my best to make it simplified for you so that you can kind of bucket them. You'll find a lot of times when we talk about the different buckets of amino acid hormones, water-soluble versus steroid, suffixes will be your friend. The water-solubles will end in IN quite a bit, and the steroids will end in ONE, okay? So you can help to memorize and, not memorize, help to learn that. Also, one of the things I told about in the beginning is memorize, or if you have to learn two lists, and one's really long and one's a lot shorter, it helps to start with the shorter list. And that'll make sense here in a little bit, okay? Do you have any questions about anything before we get started? Okay, good job. You guys got your hair blown back by a micro review, I understand? Yes, all right. It's okay. Micro's gonna be fine, you guys. Promise. Endocrine system. So, any particular? No, I don't. I'm sorry. Nothing for you for that. So, there you go. This is all. This is the lecture for today. So, see you guys. Good luck. All right. No, but honestly, this is a roll up, and it's gonna hopefully make a lot more sense. And it's not. Truthfully, it looks complicated. It's not as complicated as it looks. We start to talk about the hypothalamus. That's where people start to get really sideways. But I will tell you that clinically speaking, unless you work in a very subspecialty neurosurgical type of practice, the different nuclei of the hypothalamus aren't really 100% clinical relevant. So we're not going to memorize all of the different anatomic portions of the hypothalamus. We're going to talk about globally the hypothalamus as an organ, or as a part of an organ, I should say better, and then the hormones that it makes. All right, and generally, when you bucket those together, it makes some inhibiting hormones and some stimulating hormones. Mostly, it is a control box for the pituitary. Then the pituitary, and everybody's heard that called the master gland before, that then goes and affects other tissues in the rest of the body. All right. So, pearls of wisdom, just to start thinking about this, it's like a dimmer switch rather than a light switch, all right? So, stimulating and inhibiting hormones don't turn things on or off. They turn things up or down in general, all right, through positive and negative feedback loops, and we'll talk about exactly what that means, all right? And this is what I was talking about, just so I can mention, right? Alterations of these axes. So you have a hypothalamus creates a hormone that stimulates the production of a hormone in the pituitary that then acts upon the thyroid gland or the adrenal gland or somewhere else, right? And those permutations are endocrinology, figuring out where that's happening. What is it? Is it a pituitary problem? Is it a hypothalamic problem? Is it a problem of insensitivity in the thyroid? We're not doing that in here, okay? That is what endocrinology is. So here, we just need to figure out where it's coming from, what it's supposed to do. Fair enough? Now, does anybody remember two substances we've already talked about that act as both hormones and neurotransmitters? What's that? No? Epinephrine and norepinephrine catecholamines? All right. 88, not yet. But we talked about mostly the catecholamine hormones, right? And neurotransmitters. Norepinephrine and epinephrine, okay? So, side by side, how do they differ? Most of the time, neurotransmitters significantly faster or an onset of action, right? We talk about up or down regulation of sympathetic stimulation in the heart and then the vasovasorum of the vessels. Fast, minute, second to second changes, right? Hormones, more long-term duration in general, of course, in general, right? Oxytocin is another example. Catecholamines, right? They do two different things through two different mechanisms. One has a more significant fast effect, one has a longer term duration effect, all right? Endocrine versus exocrine. What does that mean? Endocrine means it's putting its stuff directly into the blood or interstitial fluid, all right? There's no ducts. Exocrine means it's going into a duct, usually to be excreted to the outside of the body. Usually, not always. Mucus glands, sweat glands, things like that are exocrine glands. All right. Some of our organs have endocrine and exocrine function. Anybody know one? Pancreas, exactly. Pancreas has endo and exocrine functions. Endocrine makes insulin, makes glucagon. Exocrine, it makes digestive enzymes. Okay. That's everything on this slide. Hormone action. So, we talked about up and down regulation of receptors, right? And what was the process that we discussed where something attaches to a receptor and then is taken into the skin? Endocytosis, right? And exocytosis is opposite, releases something out, right? So that's going to be what happens with a lot of these endocrine and exocrine glands, okay? So upregulation and downregulation usually not just of the hormone excretion itself, but of the receptor proteins on the outside of the cell to accept more of that hormone, okay? A good example is a hormone called hepcidin. It's made by the liver to enhance or decrease systemic iron distribution, all right? So if there's too much iron in the body, we'll downregulate the receptors, keep the iron sequestered in the cells so that it's not in circulation. If we don't have enough iron in circulation in a low iron state, say we have an anemia of some type, we'll upregulate the cells, upregulate the receptors, and the iron stores will distribute out more to the plasma than it will and get out of the cells, all right? So just an example, random example, just to understand the concept, okay? And up and down regulation, again, we have too much hormone or too much something, we downregulate for the negative feedback loop, right? In order to reduce the action of the hormone, basically. That's all that we're saying here. Upregulation, if we need more of the action of the hormone, we'll create more of the receptor proteins on the outside of the cells. And again, we're just talking about generic cells here, nothing specific. Upregulate the cells to get more enhanced action of the receptor, over the hormone, excuse me, okay? So, endocrine versus exocrine, again, distant target cells versus local action cells. We'll talk about locally acting hormones as well, which are paracrine and autocrine in just a second. But endocrine in general, the endocrine glands, again, the hypothalamus, pituitary, are not making substances that act locally. They're making substances that are going to affect tissues somewhere else in the body, right? Again, very distant, the pituitary gland from the adrenal gland, all right? Circulating versus, that's what we're talking about in that previous example, circulating hormones, the things that we measure in our blood, testosterone, cortisol, estrogen, so on and so forth, all right? Something made somewhere else to exert its effect distantly. Versus paracrine and autocrine. Now, autocrine, it says here, acts on the same cell. That could mean the same type of cell, or that could mean the same cell itself, okay? The same cell that makes the substance. Paracrine is going to act locally to cells in the region, right? A lot of paracrine action happens in the gastrointestinal system, right? So endocrine, cell type 1, goes in the blood, and it has its effect downstream on cell type 2, okay? Pituitary cells, thyroid cells, example, okay? Paracrine cells, again, within the stomach. One type of cell in the stomach, a goblet cell, works on another type of cell in the stomach or in the first part of the small intestine, right? Locally acting, paracrine, next door. And autocrine, same, right? It's either going to work on itself or it's going to work on the exact same type of cell, right? A lot faster in action, a lot shorter in duration than endocrine. Very similar to neurotransmitters, but again, different. We going okay? Too fast? Or we good? All right. General information. All right. So types, gross buckets. Amino acid versus steroid or cholesterol hormone. So water-based, water-soluble, lipid-soluble. Amino acid hormones are going to be either a single peptide, a couple of peptides, or a long-chain amino acid. All right. Whereas cholesterol is the primary backbone of the steroid hormones. Now you don't have to. This picture right here is just a generic example. This is just a generic example of a water-soluble hormone, so you don't have to worry about anything that's in that picture other than just what it looks like, the general information that it's conveying. So they're water-soluble, so it means they can be transported unbound. Okay? So they can go through the bloodstream without a transport protein, without being bound to either a specific transport protein or without being bound to albumin, which are the two main ways that our steroid hormones get around. But what is the cell membrane made of? A phospholipid bilayer, right? So they can't pass through freely because they're water soluble. So they have to attach to a receptor protein on the outside of the cell in order to make it to the inside of the cell. All right? These are the water-soluble hormones, and we're going to talk about every single one of them. This is just a table with a roll-up. Here's what I was saying. Yeah, I know. So, you'll notice that a lot of these end in like INE or IN, okay? So it's not a hard and fast rule, but the suffixes usually help with the water-soluble hormones. The other thing is, all the hypothalamic hormones, all the pituitary hormones are all water-soluble. So all of those are called something inhibiting program, hormone, something stimulating hormone, okay? So if you want to bucket them together, look at the suffix, look at where they're made. In general, they can help lead you in the right direction, okay? I know it's a long list. If this is just anatomy and physiology in this part, so it does bear a lot. Some of this is just memorization. You have to remember where they come from and what they do. But we're going to tie the names into them. Hopefully that helps, okay? And I think, just to draw your attention, and I know because a lot of you are very, very astute, I think on your slide it just says there's the missing E, thyroxine. If I could be mistaken, I know I fixed it somewhere, but if it's not, it should be thyroxine. If there's no E, it should be on there. And just in the spirit of several names, thyroxine is also called tetraiodothyronine. Tetraiodothyronine, excuse me. So, multiple names. We'll talk about that when we get to the thyroid. So steroid hormones, fat soluble. So in order to be transported, these guys in general need to be bound to some sort of transport protein. There are specific ones like sex hormone binding globulin, thyroid binding globulin, but there is also albumin, which carries a lot of hormone around itself, right? So some protein has to carry it around, rendering it temporarily water soluble before it unbinds from that protein and then makes its way through the cell membrane into the cell, okay? So these guys can go directly through because they are lipid soluble and they bind to whatever receptor they need to bind to inside the cell, all right? So difference, right? Let me go back one just in case anybody's gonna ask. The reason why also thyroid hormone has the stars is because its water solubility is very low. So most thyroid hormones will be circulated bound to some sort of transport protein. That's why there's a star, just in case anybody was going to see that next, okay? And again, right now, just take that for what it's worth. We're going to have a whole section on the thyroid. It'll make more sense later, all right? But just so you realize what the asterisks are about. We all together? Any questions? Excited, okay. All right. One person is excited. But here are, see, this is what I said, shorter list. What do you notice? Adrenal gland, adrenal gland, adrenal gland, all right? So the kidneys and the adrenal gland, which are the kidneys' hats, okay? And then the ovaries and testes and fat cells. So you can kind of make that a shorter list to remember, and then if it's not one of these, it's one of the others, right? As far as what's water soluble, what's lipid soluble. The other thing about these guys, and again, there's always exceptions, O and E, testosterone, progesterone, right? That suffix usually will lead you to the fact that this is a steroid hormone, okay? Make sense? This one right here, this cortisol box, these are all synonyms for cortisol, cortisone, corticosterone. Why? Don't ask me why. It's just the way it is, right? It's the vernacular of the medical language. It's a new language that you're all learning, and unfortunately, 3 different names for the same thing is part of it, okay? But you see how this is sort of an easier list to put together. Adrenal gland, kidney, and then the ovary, the gonads, basically, right? Fat cells, just to give you a preview, fat cells have to do with conversion of testosterone to estrogen. So we'll talk about that when we get down to the reproductive and when we talk about the gonad hormones towards the end of this, right? Just in case you're wondering. Transport, again, transport proteins, whether it be a specific something binding globulin or whether it be albumin. Generic albumin does carry a lot. Again, huge function of albumin. Why? What does it do? Maintains colloidal pressure, transports things. So when we run into situations where we're losing albumin, it's a serious medical issue. It affects the cardiovascular system, the circulatory system, the endocrine system, the hepatic and digestive system. So seemingly innocent molecule, albumin, just a plain protein, has a number of functions, okay? Free fraction. Anybody with medical background or anybody have their testosterone measured? Usually you will measure total testosterone and free testosterone. The free fraction of most hormones are the metabolically active version, because that's the part that is unbound and able then to move into the cell. It's not technically true, but in general, that's what you can consider. That the free fraction is the biologically active component of the total amount of the steroid, all right? So, other thing that binding globulins do is help maintain sort of a reserve of that steroid in the bloodstream. So if it needs more, it can be activated fairly quickly rather than having to be recreated. Also helps keep it in the kidney, because what do we say about albumin going through the kidney? I know we haven't talked about the renal system yet, but it's supposed to stay, right? It's supposed to filter and keep albumin. We're not supposed to lose albumin in our urine, right? So that hormone bound, that albumin, will then stay in circulation where it belongs. So it gives us kind of a ready reserve, all right? So multiple different functions of the transport protein. Question? Good. If that's too subtle, I don't want you guys to look at this slide. All right? Because one, it's not entirely accurate. What it did say behind that thing is that levothyroxine or Synthroid is only available orally, and that's not true. You can give intravenous levothyroxine for a condition called mixed edema coma, which is a severe hypothyroidism. So that's just gee whiz knowledge. I don't want to just cross this one out. And the other thing is, the other one said insulin is primarily water soluble, and if you take insulin orally, the peptide bonds are broken, and so it renders it biologically unavailable, which is true, but there is a significant amount of research going through right now to try to get a functional form of oral insulin, because sometimes diabetics don't like to give themselves shots. And so if you have an insulin-dependent diabetic, especially an insulin-dependent type 2 diabetic, if we can get them to take their medicine, that's better, then they don't die. We don't have to saw their feet off, right? Okay. So, enough about that. Just background. Take that one out. Questions thus far? Anybody? Over. So, what controls in general hormone secretion? Nervous system messages, chemical changes, meaning, regulation, recognition of an increase or a decrease of a certain substance that we need, glucose being one of them, right? Think about glucose regulation. How is it regulated? Glucagon, insulin primarily, right? So recognition of certain levels of electrolytes or solutes within the blood will help up or down regulate our production of these steroids. And then other hormones, when we talk about different axes, will, most of our hypothalamic hormones are messages to the pituitary to make something, and then that something goes to something else to create an effect, right? So that is an axis, so hormone action on other hormones, okay? Negative and positive feedback loop. In general, this is just a generic example of negative and positive feedback loop. So if you have a negative feedback loop, you have, as I say, some hormone from the pituitary, let's just say adrenocorticotropic hormone, right? It's going to signal our adrenal gland to make more cortisol, make more steroid. Now we have a recognition that we have a lot of that in the blood. So the adrenal gland sends a signal back to say we have enough, turn it off. So that is a negative feedback loop, right? An increase in something results in turning off the thing that's triggering the production, okay? Versus a positive feedback loop with like oxytocin during birth, dilation of the cervix, induces an increase in the production of oxytocin to help further soften and dilate the cervix until after the fetus has passed the birth canal, and then it changes to a negative feedback loop. But again, reinforcement. Oxytocin happens because of a certain physiologic action. It induces more oxytocin to happen to create and exacerbate that effect. Does that make sense, everybody? Just a generic positive feedback loop, okay? Any questions up there? Just very general endocrine action. Yeah? Yes? Okay. All right, and this is what I was talking about with the hypothalamus, okay? Multiple different nuclei, not a single unit or structure. Multiple different nuclei of a location of the brain. Now, you look at that, you're like, holy shit. Just that alone, there's like 15 things on it. And I'm telling you that we don't need to know the different nuclei of the hypothalamus, okay? We're just going to talk about the hypothalamus in general. So, to orient you, posterior, think medulla, anterior. So, this structure is the thalamus, and so anterior and inferior are the hypothalamic nuclei, okay? Hypothalamus then connected by the infundibulum to the pituitary. And that's what we're gonna go over today. We're gonna spend most of today on hypothalamus and pituitary. So, anterior, inferior to the thalamus, hypothalamus, and the infundibular stalk connects it to the posterior pituitary. All right. And that pars tuberalis, we'll talk about that later, but it's in bold now, so let me explain. There's a posterior pituitary and the anterior pituitary. The posterior pituitary is connected by the stalk. Okay. Here. The anterior pituitary is not technically connected to the hypothalamus, but this pars tuberalis I was referring to is basically that wraparound. Okay, so the anterior pituitary is the ball in the lighter brown, plus that wraparound structure on the infundibular stalk. Okay? So, seeing that, there is a direct connection from the hypothalamus to the posterior pituitary, but not to the anterior pituitary. Anatomy. Does that make sense? Okay. So, if there was a tumor or something, again, this delves sort of into endocrinology, but if there was some sort of tumor in the infundibulum, which is the stalk, the branch, most likely which part of the pituitary would be affected? Hormones going to where? The posterior, right? Because that direct connection might be occluded. Okay? Whereas in the anterior pituitary, there are vessels that go around it to feed the anterior pituitary itself. Okay? So, go back to this. Everything the hypothalamus makes has to do, or makes its way to the pituitary in some form or fashion. Alright? So the pituitary is the master gland, the hypothalamus is the master gland. Alright? The guy behind the guy. The Oz. Right? The pituitary is called the master gland because it controls the rest of the body. Hypothalamus controls the pituitary in general. Okay? And if you're orienting yourself this way, see, this is the brainstem right here, the cerebellum, so this is the brainstem, excuse me. This is the cerebellum, like I said. Anterior, that's why it's facing this direction in this picture. Anterior pituitary, posterior pituitary. Optic chiasm, interesting. So, where are you guys? Have you guys learned the nervous system at all? Have you talked about the brain yet at all? All right, optic chiasm is where the optic nerve basically crosses, right? So, a lot of times, if you have a pituitary tumor, it'll push on that optic chiasm, and it'll get what's called a bitemporal hemianopsia. You'll get a loss of vision on the outside of both eyes, or if it's big enough, you might get a complete obstruction of vision. So, if you have somebody that starts to have these weird vision problems in that sort of format, start to think their pituitary may be growing, okay? That's just some Jewish for you right now. So what triggers the hypothalamus? Again, stimuli, loss of solutes in the body, different receptors within the body, right? It could, hypoglycemia is circadian rhythms. It's just constantly collecting information through circulation, through the kidneys, through the waste products it receives and the nutrients it receives to see maintaining levels of homeostasis, essentially. Okay? These axes, these are what we were talking about. This is where you get into your endocrinology stuff here. So what does that axis mean? It means, as we go down, it'll make more sense as we talk about the individual hormones that the hypothalamus makes. But hypothalamus always to pituitary, then to something else, right? Hypothalamus, pituitary, adrenal axis. We're talking about the production of adrenal hormones, right? So when you're unpacking that in endocrinology, is where's the message being interrupted? At the hypothalamus, at the pituitary, or insensitivity in the adrenal gland, right? So that those permutations can get pretty complex. Gonadal axis and thyroidal axis, okay? So again, the hypothalamus makes something to tell the pituitary to tell those organs to do something. All right, that's what the axis is. And then there are some that just live in their own locality. Does that make sense? You guys? Everyone gets been glazed a little bit. You all right? Huh? Micro? I mean, fair enough. I understand. I just want to make sure. Yeah.
So confirming, so it's always hypothalamus, pituitary, every hormone released in the body. They'll never.
No. That's what the bottom part is. Some of them have their own. If a hypothalamus makes a hormone, it is going to tell it's going to either be stored in the pituitary or it's going to tell the pituitary to make something else. So hypothalamus, pituitary, but there are hormones that are made that aren't necessarily part of any axis whatsoever. Okay. All right, anterior pituitary. Okay. You make this easy too, just as a prelude. The posterior pituitary doesn't make anything. Everything the hypothalamus makes, it sends to the posterior pituitary, just gets stored there. All right. Anterior pituitary makes everything. Okay. So notice this. What is a portal system again? Yeah, sort of capillary bypass, right? Exactly. And that's what that is. Remember I said the anterior pituitary isn't connected physically to the hypothalamus. So how does the stuff that the hypothalamus makes get there? Through that portal system, or through those vessels. It's secreted into the blood vessels, and it makes its way into the anterior pituitary to exert whatever action it's going to have. All right? So, two different categories, large, broad categories. Releasing or stimulating hormones, and then inhibiting hormones. So let's talk about names. Growth hormone, releasing hormone. What do you think it tells the pituitary to do? Release growth hormone. Yes, and I'm not trying to be stupid. Honestly, walk through these and it sort of will help you understand, okay? Thyrotropin releasing hormone has to do with the thyroid. Corticotropin, where do you think corticotropin, and just have a guess, anybody? No, we haven't talked about it yet. What part? The adrenal cortex, exactly, right? The adrenal cortex, okay? Gonadotropin releasing hormone. Where's it ultimately going to have its effects? Testes, ovaries, right? Okay? And prolactin is pretty straightforward, all right? Releasing hormones, all right? Now, inhibiting hormones. Growth hormone, inhibiting hormone. Now, here come our secondary names. What does somato, what does that refer to? The body, in general, the body, right? And statin, stopping, if you want to call it, right? Static, if you want to think about it that way, right? So, somatostatin, right? We're going to stop the release of growth hormone, all right? Dopamine doesn't have that nice little way to remember it, but prolactin inhibiting hormone is dopamine, all right? Okay? I wish there was an easier way to remember that, just got to put those two together. So, if you're looking at this, we're focusing on the anterior pituitary right now. We have these hypothalamic nuclei making whatever hormone they're making. Comes down through and is delivered into this portal system, okay? The portal vessels take it down to be stored and distributed in the anterior pituitary, okay? Anatomically, does that make sense to everybody? So the hypothalamus makes it, It's distributed down into this portal system, and then it goes out in venous circulation. Yes?
Just like you're talking about anatomically, why does it not go to the posterior if that's the one that's connected to it?
Because these are anterior, it's a great question, and it's gonna sound like a snarky answer,
Yeah.
but because these are the anterior pituitary hormones. The other ones go to, if I could show you, I'll show you since it's a decent segue.
But there are posterior hormones.
These right here, different nuclei, come straight down the axons of the neuroendocrine cells and go directly into the posterior pituitary without the portal system, because they are connected directly. All right, does that make sense? Okay. So again, it's not snarky, but it's just like these are anterior, those are posterior. It's just that's the way it is. Okay. All right, clear enough to everybody? Sort of, maybe. Okay. Now, posterior pituitary, good segue. These are just stored, right? The posterior pituitary doesn't do anything, right? So those anterior pituitary hormones, or let me take that back and rephrase that. The hypothalamic hormones that act on the anterior pituitary make it make something else, right? So, growth hormone, releasing hormone, what do you think it tells the anterior pituitary to do? Make growth hormone, right? Anterior pituitary makes stuff. Posterior pituitary stores stuff. Okay? So, the hypothalamic hormones are already made. Oxytocin, antidiuretic hormone, they're made in the hypothalamus and stored in the posterior pituitary and then released as necessary. You see the difference? Okay? Let's go back. Okay? Hormones in the hypothalamus makes that go to the anterior pituitary cause other hormones to be synthesized by the anterior pituitary. Alright? So all of these stimulating hormones, releasing hormones, or inhibiting hormones are telling the anterior pituitary to make or to stop making something. Clear enough? Okay. Yeah? Yes.
So it's like a hormonal precursor.
This is the first part of the axis. In general, subsequent to that, when we get to the pituitary part, is going to be the thing that it tells it to make and the thing that into the organ that it goes to, right? Right. So we are making something in those nuclei of the hypothalamus. It's coming down that portal system into the anterior pituitary to incite an action, a production or a cessation of something. Does that make sense? Yeah. Who else? Oh, yes, ma'am.
So for the pituitary gland is only stored things that are made in the hypothalamus, it's not
No, that's right. Yeah. When it makes there may be a small reservoir, but in general, when the hypothalamic hormone signal come down the pituitary, it makes it and releases it in general. Okay. Again, posterior pituitary, different story, more like a garage. We got oxytocin and vasopressin. I know we haven't got there yet. That's made in hypothalamus. It goes there for storage when we need it because we're dehydrated. We need antidiuretic hormone out in circulation. Yes, sir.
So like referring back to the picture, is the posterior part of the hypothalamus that sends stuff to the anterior pituitary?
No. Everything is coming from the hypothalamus, right? So these nuclei, these yellow lines represent nuclei in the hypothalamus itself, okay? So these ones here put their stuff into this portal system to go into the anterior pituitary. These ones here make their stuff to go into the posterior pituitary, and never the twain shall meet. Does that make sense?
Yes, sir.
Okay. Does that make sense, everybody over here? You need to do it over here? Okay. Good? You sure? All right.
Just a quick question.
Yes.
That picture, so there's vascular supply between the two, but it does not allow hormones to pass.
In general, yeah. Just pick it up what I'm putting down. Okay. All right. All right. All right. So again, This side that we were just talking about, sir, axons go directly down into the posterior for storage, okay? Excuse me. And so, long-awaited oxytocin, an antidiuretic hormone, also known as ADH or vasopressin, all right? Antidiuretic hormone is named what it does, right? Antidiuretic hormone, what does that mean? It means we stop peeing. Antidiuresis, okay? Vasopressin, what does that also mean? Vasopressin, right? Yeah, vasoconstriction. So it helps increase our blood pressure, helps maintain intravascular volume, okay? And here are neurosecretory cells in the hypothalamus. Hence the name, neurosecretory, and neural cells that make something, secrete something, right? In the hypothalamic nuclei, straight down into the posterior pituitary to be held until they're needed, okay? Everybody? Yes, ma'am?
So you're saying they get stored in the capillary tunnel?
Mm-hmm. Yes.
Like, cause in my head, it's ongoing situation, right? So how do they get stored? Like,
That's a great question. Right. See if we can get somebody smarter than me in here.
Those capillary sphincters.
I mean, I'm sure they have storage vessels, I'm sure they have pituitary, I mean, to be truthful, I'm sure that it's stored in the pituitary cell versus in the bloodstream, right? So they're stored in the pituitary cells, right? And then released from the pituitary cells back into the bloodstream as necessary. Yeah. Okay. And then, all right, that's hypothalamus. Does that make sense, everybody? We on the same page? Yeah? Ish? Okay.
I have a question.
Okay, good.
So if hypothetically the posterior pituitary doesn't work anymore, will anterior pituitary pick up the function?
No. No, because those axons don't go to the same spot, and like, if you have posterior pituitary failure, you can have a loss of oxytocin, you can have a loss of antidiuretic hormone, there's something called neurogenic diabetes insipidus. It doesn't, that slack isn't picked up from the anterior pituitary, because that's, the cells don't, the neurosecretory cells don't go there, and so if you have posterior pituitary failure, you're not gonna get picked up from the anterior, so it doesn't pick up the slack, you know. Does that make sense? All right, any other questions? This is good, I like this. Anybody else? Yes?
So, maybe to piggyback on that and looking at the, kind of combined picture, I think slide 40, so we'll back looking at the anterior and posterior pituitary.
Yep.
It shows, it shows the trophic hormone secreting cells that are stimulated by the hypothalamic nuclei that go to the anterior pituitary. But then on the posterior side, it doesn't show hormone secreting cells because they don't.
Because it's not secreting anything. If anything, they're storage cells, yeah.
So then is the bulk of the mass of the posterior pituitary just the axon terminals for the hypothalamic nuclei that just hang out there? Is that where it's stored then, or are there, like I said, if it's stored somewhere?
I mean, it's stored in cells. I was being a little tongue in cheek. Yeah, they're stored. They're not literally stored in the capillaries, because again, exactly what she said would happen. Like, you can't stop the blood flow. They're stored in posterior pituitary cells. So is the bulk of the pituitary just storage space, more or less? Is that what you mean?
Yeah, so or is it actually leaving the neurons from the?
Yes, it is. It's actually leaving the neurons. It's going into the interstitial fluid. It's being stored in the cells of the posterior pituitary, and then secreted back from the cells into the bloodstream as necessary.
Okay, so it's not just hanging out in the axon terminals waiting to get released.
No.
Okay.
Yeah. Anybody else? Yes. Love it. All right. So, pituitary, ready? I appreciate the questions, you guys. Keep them coming. I love saying I don't know. So Sella turcica is the area of the skull, and I know you guys haven't done skull yet, but the area where the, where's my pen? Just the area where the pituitary sort of sits in the sella turcica of the sphenoid bone. And if you're looking, optic tract is here, so when if we get some sort of a growth of the pituitary, that's why I can envision. Right? Going back to this, different names, of course. The easiest way to remember the anterior posterior pituitary is everything we talked about with the posterior pituitary has to do with neurons, neurohypophysis, right? Adenohypophysis doesn't really help, right? But that's the anterior pituitary, okay? And again, two separate glands and two entirely separate processes. Back to whoever asked the question. Posterior pituitary won't start to do anterior pituitary functions if the posterior pituitary fails, and vice versa, okay? So the anterior pituitary, it's the largest part, glandular tissue, right? Glandular, exactly what we're talking about, those secretory cells making whatever the hypothalamus has told it to make, okay? And the pars tuberalis is that sheath. So looking at this picture, the anterior pituitary comprises not just this part here, but also this sheath here that wraps around the infundibulum. So it wraps around the stalk. The stalk itself is a part of the posterior pituitary. Does that make sense? Does it make sense?
Yeah, sorry, I was still trying to figure out what
What else pointing out where? On this one? Oh,
all of it. I've just heard a bunch of brand new words.
so the anterior pituitary is this part right here, right? But remember that it's not connected to the hypothalamus. So it comprises not just this part, not just this brown part here, but also this wraparound portion up here. So if you take the anterior pituitary away, how about that? Take the anterior pituitary away, all you're going to be left with is this dark brown piece. Does that make sense?
Yes.
So the anterior is here and wraps around the stalk that actually physically connects the hypothalamus with the posterior pituitary. All right? So everybody can see what I'm talking about? If you take this anterior pituitary away, all you're going to be left with is just hypothalamus, stalk, posterior pituitary. All right? Anterior is this part over here, and this part wrapped around.
Is that cut away?
Huh?
Is that cut away or is
This?
it? No, the.
Where it wraps around.
No, it's not it doesn't wrap all the way around. Yeah. He was asking if the pars tuberalis, that wraparound piece, is cut away. It's not. Okay.
And just clarify, the pars distalis is the actual glandular thing at the bottom of the largest portion.
Just say that one. I can't hear it.
The pars distalis is the actual glandular, the large portion.
Yeah,
at
yeah.
the bottom.
Let me go back. Let me find the picture. Yeah, it's this. The glandular tissue. Yep. So different names for the same thing. Pars nervosa, pars distalis. Right? Pars nervosa is the posterior. Pars distalis is the anterior posterior. Why is it called pars distalis? Probably because it's farthest away from the hypothalamus. That's the best I can do for that one, yeah. And let's see. Yes, the gland, and I think this is the slide you were referring to. Right? The main portion. Yeah. Okay, questions? So, good? Good. Good. You guys are making serious eye contact, right? Alright, let's see, when did we start? Lost track of time. 05. 05? Oh yeah, then let's take a break.
Whatever's produced, helmets coming down two separate things. Consider them, even though they're together, consider them two separate things.
We should be able to live from next week as the down 30 days.
They're gonna receive them. No, it's neural tissue. It's the I guess you could see it as a line of demarcation, but like it really notice a lot of these.
Even with almond milk.
Yeah, no, no sugar. I can't drink any more coffee. There are two reasons to drink it.
If you like linear coffee powders.
No, it's just like cold coffee makes me gag. I can't do coffee. I don't like iced coffee. I don't like cold coffee. Like, it literally makes me gag. Yeah.
So like all the remedies.
Can't do that. My wife loves cold coffee. She loves iced coffee. Oh, he drink my shit inside. Air conditioning.
They call them
Pictures it. So I have my hobbies and smoking me forward to bakery, so I've really like reached like pinnacle. Most of I have a pedal smoker, just I'm lazy now. I don't feel like watching a thing on Firebox. And I have it in normal, just like 22 pedal roll for just pedal roll. I usually do offset smoking, but I didn't feel like having like 10 fires at once.
It take like 10 hours.
Depending on what you're making, brisket, sure. Brisket's a little because they don't like follow the rules of physics. Well, depending on the small cut, and it can still take like forever to cook because once it hits the rut, so like you have to get a brisket to 205 because that way all of the collagen breaks down. You have to get back to the rest. So if you try to eat a brisket at like steak, if you wait until the steak, all the collagen breaks down. So when you get brisket over between like 145 to like 170, you hit the right temperature. How does that you have to like manipulate it to get up once that's rising it up to like 200. So you can take anywhere from 6 to well, you can get that up to 18 hours. There's one on the west, there's one on the west side. I haven't gone, mainly because like there's a place I found near downtown that's way better. So we go walk around there and I'm gonna get home. Well, it's not downtown, outside. So it's not like you don't have to worry about the crowd. Like after it's like right outside of like, still have it. But they know what yours are there.
Where do you wanna go for your phase two?
If they give you like 3,000, but it's the traffic and the parking, and like brings my anxiety, because it's like, managing the parking lot, I always.
Oh yeah, I visited there once, my friend was, over there, I know where you go. Yeah, there's no parking, chaotic.
You're like waiting for somebody to move. I try to go to the.
Same thing as
No, what's that? It's that one's also like based on it's not a big
She said it's a soft beginning.
You're supposed to know the end of the restaurant before they get your mark.
Yeah, I get it. Just technically.
clarify a question. We're about to actually go through the pituitary hormones right now. So yes, so that's where they're called something releasing hormone. So, yeah, so it's two different things. So if we need sunlight, we need more protein. So release All right, you guys. Let me see where I was. Any questions that you guys come up with? So, a couple of people mentioned this little light band here in the middle. This is a pars intermedia. It is part of the anterior pituitary. It's less glandular tissue. Most of the glandular tissue is in the pars distalis, like somebody did ask, I think. So it's not really, histologically, the tissue is different somewhat, so it is sort of a delineation between the anterior and posterior pituitary. But I think, based on the questions I've gotten, I would advise you to think about the anterior and posterior pituitary as two different things, all right? Two different things entirely. That way you can bucket them together. Is there a communication between? Is there circulation between? Yes, of course there is, all right? But let's not get it too fine of anatomy and physiology here. This is where we need it to be. So to answer some other questions that I danced around, just so you know, yes, yes, there is storage in the axons, the terminal axons of the posterior pituitary neurosecretory cells. There are also storage cells in there, all right? We don't need to go that far. If you understand at this point that the posterior pituitary receives hormones to store from the hypothalamus, that is good enough. Does that make sense to everybody? All right? And it's not an insult to anybody's intelligence, but literally, clinically, it doesn't matter. All right? That's where we need you to be. The hypothalamus makes these hormones that go down the axon terminals to the posterior pituitary to sit there until they're needed. And those two hormones are oxytocin and ADH. Is that fair for everybody? Okay. When I dance around a little bit these answers, it's because I don't want to go too far. If we want to go sidebar, we can talk physiology as much as you want. I just want to keep us where we all need to be. And I hope that's not insulting anybody, but that's really what I'm trying to do. Does that make sense to everybody? Okay. All right. So, anterior pituitary hormones. Again, here we go. How does the stuff from the hypothalamus get to the anterior pituitary? Portal system. Yep, right. Portal system. Right? Epiphyseal portal system. Yes, got it. Good. So, what happens when the things get to the anterior pituitary? A signal to either turn on production or turn off production. Releasing hormone or inhibiting hormone. Does that make sense to everybody? All right. The only other one, the only weirdo in the anterior pituitary is that human growth hormone affects everything, as it is named, right? Most of the other hormones that are made by the pituitary have a direct effect on a certain organ. Thyroid, adrenal gland, gonads. Okay, does that make sense? So a direct target versus HGH, which is globally effective. Fair enough? All right. And again, how do they get out? Venous circulation, hypophyseal vein. These guys right here take the stuff that the anterior pituitary makes and send it out. Okay? Where? To the superior vena cava, to the right atrium, to the right ventricle, so on and so forth. Right? Yes. Here we go. All right. So, this, these are guys making stuff. This is the portal system directly into these endocrine cells in the anterior pituitary. So the maker cells, all right? That's the pathway. And what are things being made to tell the anterior pituitary to do something? Growth hormone, releasing hormone. Corticotropin releasing hormone, right? Releasing hormones or inhibiting hormones. Those are the cells, the signals to tell these cells to do something. Are we all on the same page with that? As far as anterior pituitary. I just want to make sure, and I'm not trying to be obstinate. I want to make sure we're all on the same page with that general message. All right. So, anterior pituitary hormones. These are the cells that make them. So, what kind of cells? These kind of cells. Put them together and see if you can figure out. Somatotropin is made by somatotropes. Okay? And I'm not trying to be a dick. What does tropic mean? Does anybody know? Change, to have an effect on. Yes, exactly. So somatotropin makes somatotropes make somatotropin, human growth hormone. I don't know why I can't get that out of my mouth the right way. You guys hear that too? It's like human growth hormone. You guys want a tongue twister? Say soldiers' shoulders. Just say it. See? Can't do it. Shut up. So you're a 3-figure battalion commander saying, this activity is hurting your shoulders, and you sound like an idiot. Because you say shoulders. Anyway, what the fuck? Anyway, so HGH. By the way, if you see HGH with a small h in the beginning or a large h in the beginning, they mean the same thing. I tried to uniform it through here. I'm not trying to trick anybody. It's just, you'll see it written both ways. Just like when you see beta HCG, you see HCG with a small h. Okay, human usually delineates the smaller h, but it doesn't matter, just in case. So, thyrotropin works on the thyroid, made by thyrotropes. Okay? FSH, follicle stimulating hormone and luteinizing hormone, which we'll cover when we talk about the gonadotropes. Gonads, right? Female, male gonads. Okay? Prolactin, lactotrope. Picking that up. Lacto, lactin. Corticotropes on the adrenocorticotropic hormone. Right? So anyway, you see, the only one that's weird is melanocyte stimulating hormone, which is made by corticotropes as well. All right? So there's one weirdo. Does that make sense? If I ask what cells make what hormone, the name should help give it away. All right? And again, where are these cells located? The anterior pituitary. And they are stimulated by what? Hypothalamic hormones that travel to them how? By the portal system. You guys got it. All right? Now we're going to talk about the individual ones. We're going to get through HGH today, and I think about it's enough. I smell fire. So, somatotropin, right? Human growth hormone. Same. Know both names. All right? Most of the glandular tissue in the anterior pituitary are somatotrope. Okay? Make a lot of it before adolescence, so we have like a sharp, steep increase in adolescence, and then a gradual decline, and that decline becomes significantly sharper when we get to sort of a geriatric age. Okay? Does anybody know the difference between REM and non-REM sleep? NREM? Rapid eye movement, non-rapid eye movement. NREM is the deeper sleep, right? So it usually comes after. So the initial portion of NREM sleep is where we start to really make a lot of growth hormone. Does that make sense? What is the function of sleep? Rest and regeneration. So we're making growth hormone in order to help regenerate when we are in deep sleep. We're in the most rested and regenerative phase of sleep. Does that make sense, everybody? All right. We're not. So, anybody heard of IGFs before? Insulin-like growth factors? Some of you may or may not. HGH generally incites the production then of an insulin-like growth factor. And there are multiple of them that do multiple different actions. We're going to kind of talk about them as a group, all right? So, HGH acts on skeletal muscle, the liver, bone, right? Sort of the musculoskeletal system, cartilage even, to make and secrete these IGFs, right? And so, what do you think they're doing? They're growing skeletal muscle, cartilage, bone, all right? Human growth hormone, okay? So, there can be alterations when you get to the endocrinology of not just the hormone, not just the growth hormone, releasing hormone from the hypothalamus, not just somatotropin from the pituitary, but if the IGFs then are deficient in their production, have to unpack where along this entire axis is the problem. We're not doing that here, but I'm just telling you, anything along that axis that gets altered can result in abnormalities of growth or sustainment of growth. Does that make sense? Just based on what the IGFs do. In the bone, they make bone. They increase cartilage, at the epiphyseal plate. Everybody know what the epiphyseal plate is? The cartilage at the growth plate. You guys have heard of growth plate, right? Cartilage at the end of your long bones. As you grow, that cartilage towards the inside is replaced with bone, and that's how your bones get longer, and that's how you get bigger. All right? So HGH stimulates that during adolescence and growth. Bone turnover. So in adults, it increases bone turnover. I know you guys, again, probably haven't talked about this yet, but you have two different types of cells in the bone, osteoclasts and osteoblasts. Blast, build bone, clast, chew bone. So increased bone resorption, increased osteoclast activity to help turn over bone, remodel bone, maintain calcium homeostasis in the body, okay? Adipose tissue, one of the things that IGFs do, especially in a fasting state, is help regulate energy and help regulate glucose levels, all right? So, everybody here has heard of the keto diet, right? Ketones are released as a result of fat metabolism. In fasting states, you turn to adipose tissue because you have an insufficient amount of glucose being taken in exogenously. So in this case, if you're in a fasting state, relative even, like where you haven't eaten in a while, HGH helps convert those lipids into free fatty acids into energy. Does that make sense? Right? Long way around to say, HGH turns fat into energy if you're not eating. Easier? Make sense? Okay. Skeletal muscle anabolic. Everybody know there's between anabolism and catabolism. Okay, anabolic steroids used to make you grow. All right. So HGH, human growth hormone, anabolic effect on skeletal muscle. Does that make sense? That it should have an anabolic effect on tissue. Okay. In the liver, it further promotes. So again, remember we talked about a positive feedback cycle. So an IGF creates and begets more IGFs in the liver because that's one of the main sites of production. Excuse me. All right. And then what are all those things at the bottom? Gluconeogenesis, reduced glucose uptake into the hepatocytes, and glycogenolysis. What do they all have in common? Increasing blood levels of glucose, right? Gluconeogenesis, making new glucose, okay? Generally hand in hand with glycogenolysis. Have you guys had any of this in biochem or anywhere else yet? All right, here we go. You guys know what glycogen is? If you don't, it's the main energy carbohydrate storage in the liver, okay? IGFs will result in the breakdown of glycogen into glucose for usable energy. So from storage to use. Does that make sense? That's glycogenolysis. Glycogenolysis. What does lysis mean? Breakdown. Okay? And then you take the word gluconeogenesis, unpack that, glucose, neo, new, genesis, making new glucose, right? That's why glycogenolysis and gluconeogenesis go hand in hand. Does that make sense? Everybody? Okay. Antibiotic, I mean, all of this should make sort of intuitive, yes.
So, if you have elevated IGF levels for a long period of time, then would that
I know where you're going, we're gonna get there. Just hold on one second, hold that question for 1 second. Immune system, antibiotic production, increases immune function, right? Rest, regeneration, human growth hormone, okay? Make sense? All right, also really good for helping you hit 72 or 73 home runs even. All right, lipolysis. What is that word? Break it down. Lipo, fat, lysis, breakdown. Already talked about that, right? Counteracts the actions of insulin on lipid and glucose metabolism, right? So what is insulin trying to do in general? You guys know this without having had it. What do diabetics take insulin for? To lower their blood glucose, right? What is IGFs and HGH trying to do? Raise blood glucose. They're typically antagonistic, and that's going to get to your question that you asked in the back in just a second, okay? When I said a second, I mean a literal second, because here we are. So, high blood glucose, if there's a lot of blood glucose, hyperglycemia. Create insulin, bring it down, right? IGFs, if we have a low blood sugar situation. Well, so what does he think IGF go hand in hand with? If you know, what is the counteract? What is the evil twin brother of insulin? Glucagon, right? So they have similar net effects. Although IGFs have a much more potent effect because they also work on fatty acids and other tissues as well in order to break down to make that gluconeogenesis, right? And so I think where you were going is if you have an overabundance of HGH, if you have an overabundance of IGFs, yes, you can be chronically hyperglycemic, and that chronic hyperglycemia can eventually lead to pancreatic insulin burnout, where you're now no longer going to be able to make sufficient insulin. So it can be diabetogenic. Yes, if you have too much IGF, too much HGH, it can be a reason for a secondary or type 2 diabetes. Because eventually you'll have burnout of the pancreatic beta cells, and you'll also have insensitivity of the tissue cells to that insulin. Does that make sense? Is that what you were asking?
yes, sir.
All right. Does that make sense, everybody? Okay. So, hypoglycemia, low blood sugar, incites the hypothalamus. Remember we talked about what makes the hypothalamus make its stuff. It recognizes, it's the brain, it knows there's not enough blood sugar, okay? So, we need growth hormone releasing hormone, right? And then where does growth hormone releasing hormone go? To the anterior pituitary via the portal system to act on what kind of cells? Somatotropes to make somatotropin. Human growth hormone to do what? All the stuff we just talked about, right? Conversely, at the same time, it inhibits growth hormone inhibiting hormone, right? We don't want the hypothalamus to make an inhibiting hormone to inhibit the stuff that we need. Does that make sense? You guys? Yeah? All right. And then hyperglycemia, flip that around, okay? It's going to inhibit growth hormone releasing hormone and stimulate the release of growth hormone inhibiting hormone. Follow? It can be a mouthful. I mean, there's no other way to say it. Does that make sense though? You guys? I'm getting something like, like good enough? Like if you'll shut up, I'll say yes, that kind of thing? All right. Okay. Fair enough. And then other factor, this is a redundant slide, you guys, honestly, because we've already talked about this, that stimulate HGH secretion, obviously the releasing hormone. Exercise, we need to rebuild, right? We need to regenerate the deep NREM sleep and hypoglycemic states. And then generally, the only weird one here that we haven't really discussed too much, but it's aging. It's gonna be more at the end here. But as you age, your growth hormone production slows. All right? And here is a big or a small picture that says all of the things that I just said. Again, remember I told you I add these. If somehow this communicates to your brain better than the other slides, that's fine, but this is just a summary roll-up of pretty much everything we've just said. Okay? So this little brain nugget here is a pituitary tumor. And again, that's the kind of thing you could use that if your patients start to suffer these weird sectional vision losses, we'll call it that for now, it's sufficient for now. Start to think it may be something impeding on the optic nerve or the optic chiasm. In the first place, you would generally look after like a retinal failure would be like a pituitary problem, pituitary growth. Okay. Do a couple clinical correlation stuffs here, and then we'll get out of here. All right. So HGH hypersecretion in childhood. Anybody heard of Robert Wadlow? Alright, so HGH hypersecretion in childhood. Are your growth plates open or closed in childhood? Open, that's how you become a grown-up, right? So HGH hypersecretion in childhood enhances cartilagenesis, that's a hard word to say, chondrogenesis in your epiphyseal growth plates. What does that mean? It means it makes more cartilage at the tips of your bones that then remodel to become bone. So your bones grow at an abnormal rate, but at a semi-normal proportional level, right? So you're huge and tall, but you're sort of proportional to a certain extent. And we're going to contrast this to acromegaly here in just a minute, all right? But does it make sense why they would have hyperglycemia? Based on what we just talked about the functions of HGH. Okay? Too much HGH, releasing too much new glucose, making too much new glucose, breaking down fatty acids to make energy. These patients often experience diabetes or insulin burnout, pancreatic insufficiency of some type. Okay? So this is just, you don't have this, but again, what's happening is right here, right? The way that bones grow is the proximal, like if you're looking at the proximal portion of that bone, the long bone of metaphysis, right, that's growing as the epiphysis, as the epiphysis remodels. So cartilage, extra cartilage becomes extra bone, longer and longer, larger and larger bones, essentially, okay? And that's Robert Wadlow. This guy, obviously. Look at this chart there, right? You can sort of see the uptake, right? He was relatively normal birth, right? No record of his height, but 8.5-pound baby is not abnormal. Okay? Then you would go and you would say maybe a 5'4" 5-year-old is pretty atypical. And then a 6'5" 10-year-old who weighs 210 pounds. And then it says sick here, so this is when he really starts to experience a lot of problems because these patients start to have some surreal health issues. Especially, I mean, this is a unique case. But 17 years old, 8 foot tall, 315 pounds. What do you think, if you had to guess, what do you think the main organ suffering in this patient would be?
It's hard.
His heart. You know how hard it has to work to pump blood through 8 foot 11 inches of body. His heart was like, I mean, a cow heart. You remember the cow heart? His heart was probably that big or maybe bigger by the time he died, honestly. And so heart failure, I think, is how he actually did die, or maybe a pulmonary infection. But this is obviously not a real picture, but superimposed against Andre the Giant, that is Robert Wadlow. Andre the Giant had something that we call acromegaly, which is HGH hypersecretion in adulthood. So even though he was abnormally tall, it was more towards the end of his adolescence that he started to experience that. And so he, instead of remodeling and growing the bones, what it really causes is a thickening and growth of the bone. Anybody ever heard of something called frontal bossing, where you have large frontal cranial area, right? Big, thick bones. You see sort of, I mean, I have a better picture of it. So look at this one right here. So fairly normal features, right? And then you start to see this growth and enlargement of the jaw, of the nasal bones, of the forehead, the frontal bones, frontal bossing. So you have a growth of the frontal bones. And if it is left unchecked, you see, you know, her fingers, her hands, thick, wide fingers, big, huge features, right? And the opposite would be HGH hyposecretion in childhood, and that would be congenital dwarfism, okay? And that is the opposite because in this case, epiphyseal plates close, because HGH is one of the things that helps keep them open during childhood and adolescence for normal physiologic anatomic growth. So if they close prematurely, then patients have a short stature, okay? And does anybody know who that is? I'm talking about HGH and aging, reversing the aging process. Huh? Conso de Leon? Fountain of Youth, anybody? No? Okay. Alright. Just read a book. Alright. Alright, questions? That's it for today. That's all we can do. Any questions? So we got it. We haven't finished the anterior pituitary. We haven't started the posterior pituitary, but conceptual. Do we understand how things and what things are made in the hypothalamus and how they get to their respective parts of the pituitary, which we shall consider two separate things? Is everybody at least there? Okay, good. I'll see you later.